Hi everyone, and welcome to the second session of Digitodontics Webinar Series. This is Mahmoud Al-Bashti with you today from Digitodontics International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Najla Chebib from the University of Geneva, Switzerland. Dr. Chebib will share with us her experience in digital scans in removable prosthodontics. Dr. Najla Chebib is a full-time senior lecturer at the Division of Gerodontology and Removable Prosthodontics of the University Clinics of Dental Medicine, University of Geneva. In 1999, she obtained her degree in dentistry from St. Joseph University in Beirut, Lebanon. Then proceed advanced training in general dentistry at Boston University, before returning to Lebanon and completing the training in prosthetics and biomaterials. She has held several positions, teaching positions at the St. Joseph University in Lebanon, but also at Tufts University in the United States, where she directed the postgraduate program in aesthetic and restorative dentistry. In 2016, she started working at the University of Geneva at the Removable Prosthesis and Gerodontology Division. Since then, she divides her time between research, teaching, and clinical activities. In 2019, she obtained her doctorate from the University of Geneva. Her research interests focus on simplifying prosthesis fabrication techniques through the use of intraoral digital impressions and printing or milled prosthesis. She is also interested in strategies that highlights how certain diseases, such as malnutrition or pneumonia, can be avoided by maintaining a healthy and functional mouth. During this webinar, Dr. Chebib will delve into the advancement in digital scanning technology and their application in removable prosthodontics. From intraoral scanning to CAD/CAM technology, she will explore how these digital tools have transformed the way we approach removable prosthodontics. So, just before Dr. Najla starts, I would like to raise your attention that you can write down your questions on the Q&A section. And basically, after she finishes the research part, if you have any questions regarding research, so she can answer those kind of questions. And if you have any clinical questions, so she will answer them after the clinical cases that she will present it for us. So without any delay, once again, let us welcome Dr. Najla with us today. Najla, thank you so much for accepting our invitation to be with us today. I think the stage is yours. Please share your screen.
Hello, everyone. Thank you for being here for this webinar. And I would like to start by thanking the Digitodontics Academy for giving me this opportunity. I think they have an outstanding website and a very nice source of information. Today we're going to be talking about digital scans in the area of removable prosthodontics, and we're going to cover a couple subjects. The first is we're going to look at the feasibility of those scans. We're going to look at the quality. Are they good enough? Are they as good as conventional impressions? And we're going to look at how we integrate all this knowledge into the clinical practice and how we can apply those technological advancements in our daily clinical activities. I know we're not a big group, so please don't hesitate to ask questions, and I will give a little bit of time at the middle of the webinar so we can have a little bit of an interactive talk. There's a lot of research at the beginning, and I know a lot of my seminars are attended by postgraduate residents and students that are doing advanced training in prosthetic dentistry. So I'll be very happy to answer your questions. And for all those clinicians, you're going to see a lot of clinical cases in the second part of the presentation, and I will show different workflows. So please don't hesitate to put questions in the chat for Mahmoud to relay the questions to me. So today, when we talk about scanners, we know that different technologies are used for scanning in 3 dimensions. They differ in the scanning technology principle, whether it's by triangulation or confocal microscopy. And some, they take a single image or a video acquisition, some still, some surface preparation like powdering, and others don't. What's important is to understand the particularities of each scanner or the scanner that you have at hand, so we can get the best accuracy out of the scanner. Various factors can affect the accuracy, and here I pulled some of the information that we have in the data, and you can see there are some operator factors, like what scanner are we using? Did we calibrate? Is the temperature okay where we're scanning? How we're scanning? And then we have patient-related factors. Are we scanning the anterior area? Are we scanning the posterior area? Are we scanning the whole mouth on implants? So there's a lot of factors that can vary when we are scanning clinical scenarios. And also, we know that the more you get used to scanning, the more accurate is your scan. Because sometimes you want to scan really quickly, but then you miss some areas and you go back, you scan them again. Sometimes you scan very slowly, then you have a lot of information and the scan may not be as good of a quality. So it's important also to have this small learning curve that allows us to have a good quality scan. So we know that it works for fixed restorations and small sections in the mouth. The question is it feasible for the edentulous jaw? So when we're scanning an edentulous jaw, we have also a scanning strategy that we follow. So we start always by scanning the ridge, and then we do the buccal part, and then we go and finalize what's missing in the palate and whatever is missing also in the buccal corridor. Why do we want to move to a digital impression? Because we don't want to be using any compound material anymore. We don't want to use impression materials. We don't want any deformation of the tissue. We don't want to have casts. We want to have something that's easily stored, easily transferred for remote fabrication. We want more patient comfort. And we know that the scans are faster. It takes around 2 to 3 minutes to finish a scan of an edentulous jaw. And we know that it's a smoother learning curve for young professionals. And I know that a lot of our students, they kind of struggle when they first touch the compound material. They don't know how to mold the tissues. And it's a very difficult step for them at the beginning. It becomes easier with time, but with the digital, it's very intuitive for our younger professionals. So here you see 10 scans of edentulous maxillas, and these are from a study that we conducted, and you can see all shapes and sizes. If you look at number 10, you can see that he has a very large palate. I'm sure he's a male, I'm not sure. And usually the deviations in palatal precisions increase when we have a very large palate, because we have a large zone or large area that's very smooth around the palate, and that's that might give us some problems while scanning and some problems in the accuracy. But if the palatal vault is high and it doesn't, we've seen that it doesn't affect the accuracy. So here you have a lot of sizes and shape also for the maxilla. So what about other situations? For the partially edentulous, it's easy, except for this case on the lower, we had a very thin ridge. So it's this. Do you see my my cursor? I'm not sure.
Yes,
so
yes, it's a clear.
Okay. So you see here on the lower, the ridge was very thin, and we had a lot of saliva, and the patient was not cooperative. So we were not able to do so. In some cases, it's very difficult to get to register the arch, especially when the ridge is thin and you have saliva. Here, sometimes when you're scanning, you have errors in stitching. So when you have that, you just throw it out and restart scanning. Here we have, this is for you, Mahmoud. It's a scan of an edentulous patient who needed, not an edentulous, a patient who needed an obturator. So we didn't want to, yeah, maxillectomy patient. And we did not want to put the alginate all the way to the orbit. So we started with the digital impression, and we were able to get some of the defect. And with this, we have fabricated a custom tray, and we took the impression conventionally. In here, you can see also a very nice upper ridge that was, we were able to register that. But on the lower, we have some missing information here. And this information might be useful when we're doing a denture. So when we have a simple geometry covered with saliva, we have some problems taking the impression. We have some better saliva control in the maxilla, so we have less problems in the maxilla. But sometimes the access to the posterior areas, like if you want to register the tuberosity, it can be difficult with the size of the camera. And also with the digital scan, we have no pressure. And when we have a firm ridge, the impression is very easy to do. And at the ridge level, I think we've seen from studies is that the accuracy is comparable to conventional impressions. So when we do a conventional impression, what we do is we take a thermoplastic material and we register the functional borders in section, like you see here. You get some time, you spend some time, you chit-chat with the patient. And most importantly, you can test the retention of your impression. So you keep extending until you get that suction effect. And this is something that we don't have in digital when we're doing digital impressions. So why stay conventional? Because it works, and we have been doing that for many years. We have a functional molding of the borders. We can compress the tissues, and we will extend as much as needed, and we will only stop the impression until we have tested the retention and evaluated that with my impression, I'm going to get the suction and the retention that I need in my future denture. So how do we evaluate? We know it's feasible, but what about the quality of the scan? We know that complete denture success depends on the quality of the impression, but other factors can play an important role, such as the teeth position, the occlusion, the neuromuscular control, the initial anatomical situation, whether the patient has a good ridge or a poor anatomical ridge, and the fabrication method, where it's printed, milled, or fabricated conventionally. In fixed restorations, we know it works very easily. We scan the preparation, we design it, we mill it, we bring it, we place it on the prep. And if the marginal fit of the restoration is adequate, we know that the scan was good and all my workflow was adequate. So when we're doing implant dentistry, we scan the implant, and if my restoration fits in the interproximal space and the occlusion is correct, we know that it works. So we kept thinking, how do we evaluate the scan for complete denture? So we came up with the idea of comparing this scan to other impression materials and technique that we already know, and this is a way for us to evaluate the quality of the scan and to see how do they compare to methods and technique that we know, and we know the outcome of a border molded impression. We know that it's going to give us a good denture. We've been doing that for many years. So what we did is we conducted a study where we tried to compare the trueness of completely edentulous jaw impressions taken with alginate, polyvinyl siloxane, and polyvinyl siloxane modified with zinc eugenol, oxide eugenol at the inner seal, the intraoral scanner, and we compared all 4 impressions to the conventionally border molded zinc oxide eugenol impression that we have considered as a control impression or like a gold standard. So how did we do that? The first notion that I want to open the parenthesis and explain how these comparisons are made and how we evaluate scans in general. And this is going to give you a better understanding of the published research about accuracy. So 2 things: the trueness. It's described as the deviation of each tested impression from the original geometry. And the precision is the deviations between the impressions within a test group. And you can see here the arrow for the trueness and the arrow for the precision. So let's say if you have an object that you can hold in your hands and you can measure accurately because it has angles like a piece of Lego. And also, you know that the dimensions are given by the manufacturer. So you know the dimensions. We can take a ruler and measure that. What we do, we can scan it, and then you can measure. And you can see if your scanner is giving you exactly the same measures as the real object. And this is going to give you trueness. And if you scan it a couple times, it can give you the precision of the scan. So of your scanner. In this case, what we did with the Lego is we scanned it a couple times to see precision, and we scanned it a couple times to see the trueness. And what we combined all the information, and we saw that it was 1 micron larger than the dimension provided by the manufacturer. So when we're doing superimpositions for an object that doesn't have a geometry or a defined geometry, what we do, we define a reference usually. So like in this case, this is the zinc oxide eugenol impression. And this is the test scan. So the scan that we want to see if it deviates from the original geometry. And we have a software that can put see the common points between those two scans and superimpose them and give us an initial alignment, and then it will improve the alignment. And then we can ask the software to compile all the points in the first scan and the second scan and give us the deviations in the three-dimensional space. And it gives us like a number of values. So the minimum deviation, the maximum deviation, the average deviation, and a value called root mean square. And this is the value that you see in most studies. So this value accounts for all positive and negative deviations. So when we have two scans that are one on top of the other, we have points that can be below zero, so underneath the reference, or on top of the reference. And if you have a point that's minus 1 millimeter below the reference and another point that's plus 1 millimeter above the reference, then the average is zero, but it's not true. So the reason we use this mathematical formula is for us to account for all the deviations, whether they're positive or negative. And this can give us the software can do all the math and give us the result of the deviation between the 150,000 points that are being compared when we compare two scans. So if we get back to our study, we recruited 12 patients. We did 5 impressions. We asked them also to fill a questionnaire. We had a total of 60 scans and 5 regions that we studied. And we were trying to divide the scan into those regions so we can understand where the deviations are located. So this is the result of all the color maps that are given by the software. And you can see here we have the first group is the alginate, where you have a lot of red on the borders. This indicates that the alginate is overextended. And here we have the polyvinyl siloxane, where we have, if you look on all this group, you have a lot of blue on the borders. And this indicates that the polyvinyl siloxane impression was underextended when compared to the gold standard. And here you have the second group with the polyvinyl siloxane modified by the zinc oxide eugenol around the inner seal. And here you see some improvement at the borders. If you look at this one, for instance, you have now a little bit more compression in the inner seal. And when you compare it to this one, let's say this is the same patient. And here is our digital scan group. So what we found is that the intraoral scanner had similar deviations as the polyvinyl siloxane and the polyvinyl siloxane modified. So our digital impression had the same quality of a silicone. That's what it means. But we also, and a silicone can give us a clinically acceptable impression. What we saw is that sometimes the digital scan was short of the border molded impression, or was at that border, the impression was completely missing. And sometimes what we saw is that it was negative. So there was a lot of blue, no compression from the intraoral scan. And we saw that most of the deviations were happening at the peripheral border. So we had around 55% of that surface that was positive. So it was different from the zinc oxide eugenol of on average of 1 millimeter. And we had 44% of the border that was negative 1 millimeter. So the border is a very important part of a denture-bearing impression. And the border determination has been investigated also by other groups. And this is a study from a group from Italy that publishes a lot also on digital technologies and digital impressions for removable. So what they said is that if you do the superimposition between an impression and like a digital impression and conventional impression, you may have deviations, and all the deviations are at the border. But if you trim the border to where you want to finish your denture, or where your intraoral scan is finished, you will have a lot less deviations, and you will have accuracy values that are around 0.02 millimeter. So basically, you will have a very good scan. This is in accord with what we've said in the first study, where the ridge area and all the errors basically are around the border, because we are comparing two different things. We are comparing an impression of the tissues as they are when we're doing a digital impression, and we are comparing to a conventional impression where we have a border molded border. So it's a little bit different. So how do we determine the border when we're doing a digital impression? And that's a very important question, and something very important to understand. So when we are doing a digital impression, you see my mouse, the technician goes tack, 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 tack. He defines little points here that you see. And this is how the border of the denture is determined. And you have no information whatsoever on the compressibility of the tissues. And this is what, and it's a little bit arbitrary. So they try to see where the movable tissue ends and where is the tissue that is adherent is present. So we have been talking about the borders. What does the border look like? Here you can see 5 denture bases. And these denture bases, the 2 on the left, are made out of an intraoral scan. They're all for the same patient. So the 2 on the left are made out of an intraoral scan, and the 3 on the right are made out of a conventional impression. And if you can see here, that little folding that you have at the border that you don't find in the intraoral scan, this is what we're trying to explain in the studies, where the border is slightly different when you do a digital impression or conventional impression. So here in those 5 denture bases, you have one that was 3 of those were fabricated out of the conventional impression, and 2 were fabricated out of the intraoral scan, and they were either printed or milled. So why do we mill? Because we have the possibility of milling the base and the base with the teeth. We have a good fit, good retention, good surface rugosity, and we have decreased laboratory time and cost. And most important thing is that we can keep a digital record of the fabrication process. So why do we mill? Because why do we print? Because we have less material waste, we have good detail reproduction, and it can potentially be multi-chromatic, so have different colors. It's less expensive and sophisticated equipment, and we can hopefully produce large quantities in less time and reduce the fees that are associated with complete denture fabrications. So we have asked other questions. So if we can do the impression with the digital scan? And does it influence the fit or the retention of the base? And if I printed or mill it, does it influence the end result? Am I gonna have a denture base that has a better fit and a better retention if it's printed or milled or done conventionally? And is there a workflow that gives us a better result than another one? So what we did is that we conducted a clinical study where we saw the patients 4 times. The first time we did the screening, got informed consent, and we did an alginate. On the second visit, we did 2 types of impression, the digital impression and the conventional impression. And on visit 3, we did some retention testing, and then we asked the patient to fill a questionnaire. And then we took those denture bases and scanned them with a laboratory scanner. And then we stored them in saliva. And on visit 4, we redid the retention testing after the 2 weeks of storage in saliva to simulate that patients wore those dentures. And we asked them again to fill the questionnaires. And again, we scanned the bases. So for each patient, we had a conventional impression. And out of this conventional impression, we have fabricated a conventional base, a milled base, and a printed base. And out of the intraoral scan, we have fabricated a milled base and the printed base. To test the retention, we have imagined basically a platform placed in the center of the denture base. And it has a central hook and it has 3 notches that standardize the direction of the applied force. And here we used a traction dynamometer that gives us how much force do we need to dislodge the base, the denture base. And it can be, the traction is against the post dam, against the right tuberosity, and against the left tuberosity. To conduct also our study, we needed to standardize the place of that central platform. So when we did the conventional impression, we scanned it. And then we obtained the scan of the impression. And then we asked the lab technician to pour it and gave us the model for that impression that we scanned also with the laboratory scanner. And then we sent the model to the lab technician so he can fabricate the conventional denture base that we scanned. And the conventional denture base, we scanned the intaglio of the conventional base and the external surface where the lab technician has placed our standardized platform. And then we send the scan of the platform to the manufacturing center so he can, out of the scan of the platform on the conventional base, place the same platform on the milled base and the printed base. And to confirm that the position is in the same exact position for all the bases, we did the superimposition, and you could see that the platform is placed in the same position for all 5 denture bases. So we have 5 denture bases. And like I said, 2 were done out of the digital impression and 3 were fabricated out of the conventional impression. So what we did is we placed them in the mouth, we waited a minute, and then we took our traction dynamometer and we pulled the denture base until it's dislodged. And we repeated 3 times in the 3 directions, the post-dam, the right tuberosity, and the left tuberosity. After this session, we took those denture bases, we scanned them, and then we put them in artificial saliva. And then we went to retention testing number 2, also in a randomized order, and we asked the patient to give us also a subjective evaluation of the different denture bases that they had in the mouth. To evaluate the fit of these bases, we also use the same technique that I showed you in the first study. So we have a reference, and here in this case is the stone model. So the model that we scanned, and on that we had fabricated the conventional impression. And the stone model was considered as the reference for the conventional base, the milled base, and the printed base out of the conventional impression. And the reference for the milled base and the printed base were the intraoral scans. And we went with the same workflow for the comparisons. So we took the reference, the test base, we did an initial alignment, a best fit, and then we got the 3D comparison color map, and then we got the different values that we get from the software with the minimum, the maximum, the average, and the root mean square. We did, we placed the threshold of acceptability at 550 microns, and we took the average deviation and the root mean square for our analysis. So for the fit, what we have found is that the fit was very good, and all the values were around 0.2 millimeters, regardless of the fabrication method. So whether it was fabricated conventionally, milled, or printed, the fit was very good, and there was no significant difference in the fit, whether they were fabricated out of the conventional impression or the digital impression. So if we talk about the retention of the bases fabricated from the conventional impressions had a similar retention regardless of the fabrication technique. A significant difference was recorded on one side when the conventional base, where the conventional base had less retention than the printed and the milled. And after 2 weeks of immersion in saliva, the conventional base also had a lower retention. So there was no difference in the retention of the milled and printed bases when fabricated from the digital impression. A difference was noted after on the milled base after immersion of saliva. So what we found is that retention was the same regardless of the fabrication method. But when we compared the two workflows, meaning the bases fabricated from the conventional impressions and the one fabricated from the digital scan, we can see an important difference. And the mean retention for the conventional is around 15 Newton, and for the digital flow, it's around 6 Newton. And this is before and after immersion in saliva. So we have 2 to 3 times less retention in the digital workflow than in the conventional workflow. So we wanted to see where those discrepancies are coming from. And we wanted to look at what's different between the two impressions. So we used also the same superimposition, and we asked the software to look for the deviations from the superimposed STL. And this is this color map illustrates the variation, and the color yellow represents all the compressions that were done during the conventional impression. So you see where the compression, the positive deviations are represented in red, and it means that the test scan is more coronal to the reference model. So it means it's higher. So the reference model is the model that was used, that was when the conventional impression was poured. So you have all these areas that were compressed by the conventional impression, something that we don't see when we do an intraoral scan. And the average deviation was around 0.45, which is not a very big deviation, but what it tells us is that models may need to be modified. So to conclude this study, and we passed to the clinical cases, what we saw is that conventional impressions comprising clinical steps like compression and border molding still seem to outperform digital impressions. And the method of fabrication does not have a significant influence on retention or fit. And digital models made from intraoral scan may need to be modified prior to the fabrication of the bases. So what we saw is that we have problems in the fact that we are not compressing those tissues. So what I recommend is that when you're doing a digital impression and you're faced, let's say, for instance, with a ridge anatomy like this one, where you don't have a tuberosity, it's a flat ridge, it's a flat palate, no vestibule. So what we suggest is to palpate the tissues and modify the virtual model to add selective pressure. And to do that, you could use the digital wax knife and modify your digital model. And this way you can add some retentive compressive areas to your impression. So where does this all apply? I'm gonna go and now see if you have any questions about the first part, where I've showed you a little bit of our work on digital impressions. Do we have any questions?
Not yet.
Okay. So we're gonna continue.
Okay.
With how do we apply all this knowledge to our day-to-day practice? And I grouped all the application, and where those applications are validated, and you're going to see all the workflows. So this is a first case of a patient who presented to me, and she's 45, so very young patient, diabetic, smoker, and referred to me for a prosthetic solution. So if you look at the case, we have a severe periodontal disease, we have teeth malpositions, and we have big spaces in between the teeth. So we have decided to go with an immediate upper denture and to do maintenance of the lower teeth, and only to extract 2 teeth on the left hand side, the molars, because they were actively beyond restorability. So what I did is I took an upper scan and the lower scan with the 3 shape, and I have sent this information to a manufacturing center. And what they do is that they can superimpose the information that you give them as the teeth positions, and they come up with a teeth setup that they can send you. And here I try to personalize the anterior teeth setup so that the patient, the denture looks like her own teeth, and the patient doesn't want to feel that she's wearing a denture. And here is the denture completed, the immediate denture after extraction and insertion in the mouth. And here in this case, the denture had a milled base and teeth that were from the manufacturer, so stock teeth. After healing, I have two options. So I can either scan the new anatomy and restart my workflow process, or I can take a physical impression with the actual denture, and this is what I did. And then I scanned it with a laboratory scanner, and then I scanned it again with an intraoral scanner just for the sake of this presentation or for the sake of just understanding the discrepancies. So first of all, I was able to scan my reline impression with the intraoral scanner, and it was a very easy process. And I was able to scan it also, definitely with the lab scanner. And the comparison of the two impressions was very good, and we had deviations around 0.2 millimeter. And this is the final denture. And the patient was very satisfied with the aesthetics. This is another case, and you see lots of immediate denture cases because this is when I feel like you need to move on with the workflow and give a solution as fast as possible to the patient. So this is a case also that I saw with one of my my colleagues here at the school. So the patient came, he was hospitalized for a very long time. And then when he came out of the hospital, he had lost, as you can see, he had root tips, he couldn't eat, he had one implant still here, one implant here, but was not able to function in his current situation, and he needed a solution really quickly. So what we did on the first session, and we scanned the upper, scanned the lower, and here you can see there's something red here. We used resin to raise the vertical a little bit and be able to register an interocclusal relationship between the upper and lower on the intraoral scan and relate the upper and the lower. So we used a stop here, and we've placed it on the existing abutment. So we have that record. We sent it also to a manufacturing center. And here, when they send you the design, you can give them some feedback and ask them to change a little bit the design as you see fit. So you have to get involved. And this is the denture once it was inserted. It's not the most beautiful denture. This is an immediate denture. This is a denture that we place in the mouth a couple days after we take our scan, just to get the patient functioning normally. So after we did this immediate denture, we went ahead again and scanned this denture. And what we did is we used the scan to print a surgical guide. And we used that surgical guide to guide us to place more implants. So here we use the scanner to fabricate the initial denture, the immediate denture, and then we've scanned this immediate denture so we could use it as a surgical guide. And here it was all done with the intraoral scanner. This is also a case of a full digital workflow of an immediate denture. Here you can see the cases that I'm showing are cases where if you want to do an alginate, it's very difficult because you have a lot of interdental spaces, and the alginate gets stuck in there, and you have distortions, and you have an impression that's very uncomfortable to the patient. You're afraid to pull out teeth when you're taking the impression. You can't do border molding. You can't use Impregam or like a silicone because it might also be difficult to control the quality of the impression. So for this patient, if you look at this case, we have a little bit of like a B maxillary protrusion with the lip incompetency and a very long face. And you can see here all the lower teeth were severely compromised, and we needed to do something really quickly. So what we did is that we scanned the lower teeth, and you can see even here, the area where the ridge was very thin, we were successful in scanning that area. Even here also in the lower anterior area, this information here is important, is crucial, because this is where we're going to finish our denture. And we had a successful scan of the upper and the lower, and because we still had some teeth, so we were able to take the intermaxillary relationship. And in this case also, this scan was very precious because we had somehow a very particular situation in the lower jaw with the teeth that are set, the natural teeth that are set way more buccal than the ridge. So this is the immediate denture. We extracted the teeth and placed the immediate denture. And with the information that we gave the scan, we were able to get a good reproduction of the contour in the anterior area and in the posterior area. And I can tell you on that edentulous ridge, we did not need to do any fitting of the immediate denture, and even on the teeth, that immediate denture was well fitting and retentive. Another case also of a difficult situation, patient very old in her 90s and with severe caries all on the lower anterior teeth, we see periapical lesions and infections. She had still one implant on the top, a repaired upper denture. So it was a difficult situation because we needed to extract the lower, do an immediate denture on the lower, and then remake an upper and a lower denture. So to do an immediate denture, we had to deal with what we had on the top, and the top denture had a lot of problems with wear and fracture and multiple problems in the occlusal plane. So what we did first is we did place some composite on the upper denture, so we could have two planes that are almost at the same level. Because when we're doing a milled denture, we cannot have huge discrepancies in the occlusal plane. It needs to be somehow in the same position all over the arch. So we adjusted a little bit the upper occlusal plane, and then we registered the lower anatomy, and you see there's nothing impossible at registering a lower arch. It's slightly more difficult than the upper arch, but there's no problem. And we also removed the teeth, inserted the immediate denture, and then we moved on. We did a conventional impression bite registration for, the second set of prosthetic dentures, and you see the laboratory steps of designing the new complete dentures. And here you have our wax rims that are superimposed to the to the design that the technician is doing. And then usually they send us, I will show a little later how the technician sends me the design so I can approve it before the manufacturing of the denture. And here in this case, because these were the final dentures, we did a try-in, and here the lab technician can send you the printed try-in of the denture, where you can try everything, the fit, the occlusal scheme. You can even ask your patient to chew on those something and to try to see if they're staying, if they're fitting well, if the retention is well. And of course you evaluate the aesthetics. And here in this case, we thought that, you know, we could have, we could bring the anterior area a little bit more to the palate. So we did another try-in, and we changed a little bit the interior design. And I'm showing you here in the photo something that is a great advantage to the try-in imprinted, is that you can try your occlusal scheme. See here, we asked the patient to go to the lateral sides, to the left side, to the protrusion. And we saw that our occlusal scheme is really balanced, that it's not just because we can't do that when we have teeth that are mounted on wax. We can't ask the patient to go side to side, go to the front. And here in this case, it's almost like you have your final denture in front of you, and you can correct anything that you want at this stage, and the lab technician can reproduce on the final denture. Here you have, in this case, this is a fully milled evotion denture. So the teeth are in resin and the base also in resin. So when we're doing a conventional flow, we go with the primary impression, a definitive impression, a bite registration, teeth try-in, and the final denture. When we're doing a digital workflow, we start with the scan, and then we have somehow a bite registration and correction of the scan. And this needs to be done somehow physically. If you don't have any teeth, you have to register this interocclusal relationship with a device. You can include facial scans, but I think from my experience, you still need some kind of Gothic arch to get the centric relation correctly. And then you have a lab part, which is the digital design. So this is not a real clinical session. And then you have the try-in denture. And the try-in denture is a printed or a milled copy of your design. And it's not a step that is mandatory. I mean, I always do a try-in just to make sure that everything is the way I want, and if there's anything that I want to correct. But if you're doing an immediate denture, or you're doing a denture and then you're doing something else, implants, and then this is not a necessary step. I would say not absolutely necessary. And then you can go to the final denture, and this way you have done your workflow in 3 sessions. I want to show you a workflow where you can do your dentures if you have a completely edentulous patient on top and on the bottom, and you don't have any dentures or anything to start with. So this is my patient, okay? We have decided to do a complete upper and complete lower denture, and we started with the upper scan and the lower scan. And then I use this device that you see here, or how I'm doing it with the patient. So I determined VDO prior to putting this. And then I put putty on top and on the bottom. And I put it in the mouth of the patient. And I asked the patient to close the mouth and to swallow. So closing the mouth until I tell them to stop, and to swallow so they can go into a centric relation. And then you have this centric tray that has the putty on top and on the bottom that you can scan with your intraoral scanner, and it allows you to put together the upper and the lower arch. So on that centric tray also, you have a face bowl or similar to a face bowl where you can tell your technician the angulation of that centric tray according to the bipupillar line so that they can mount your upper and lower cast and get the angulation of the maxilla like what you would do in real life. If you're doing a conventional denture, you always take a face bowl to kind of put the maxilla as it relates to the head, to the bipupillary line. So the centric tray, the one that has the putty on top and on the bottom, can be scanned intraorally with the intraoral scanner. And there's a scanner from 3Shape that where it clips inside that small piece, and then the scanner is able to scan the upper and the lower part of this in one scan. And this gives the lab technician all the information so that they can articulate the two intraoral scans. And what they do is they give you wax rims, milled wax rims on the top and on the bottom. And on those milled wax rims, you can do your clip. You can clip these pieces so you can do your Gothic arch tracing. So now we are on session 2. What you could do, you confirm that your vertical dimension is correct. You can correct your impression if you need. You can retake your impression, like here, what she did. What we did together is that we retook the impression because our borders were overextended and we had to adjust the milled base. So we did so you correct your impression and then you take your Gothic arch tracing and then you put all the anatomical landmarks that you would put when you're doing wax rims. So you define the midline, the spine line, the canine line, and you are defining centric relation and vertical dimension. And then you ask your technician to do the design and to send you a printed or a milled try-in that you can try. And also you can try the aesthetics and you can try the functional, the balanced occlusion, and you can even give them to the patient so they can try them at home and give you feedback. And then you can finalize. And here also in this situation, we did a fully milled evotion denture. When I always talk about the digital design, I always think that the digital design is very important. And this is a case of mine where I wanted to do a class 3 occlusion, and I also used like a neutral zone, and when we're doing digital workflows, it's very easy to use that concept and it can be easily reproduced in the lab. But my idea is for me to show you this slide is to tell you that you have to get involved in digital design. It's a collaborative process. Your lab needs your feedback, whether this is exactly what you were thinking. Did you want to have a class 3 relationship? And they send you the digital design. And if you don't like the digital design and you tell them that this is not what you were looking for, that they can also print you a couple designs. They can send you this design or another design. So there's you can try the occlusal scheme and see if this is what you have registered, if this is what the patient can function with. And this is very important in the digital workflow, and a very important step because it allows us to do a lot of modifications without it being redoing the whole work. So another application of the intraoral scanners or the scanners in general is when you have a lab scanner, it's very easy to duplicate an existing prosthesis. So I have this prosthesis. I thought, okay, this is looking good. All I want is just add a little bit on the buckle. I want the teeth to be higher, like a little bit more to the buckle. So you can do your modifications. You can scan your existing denture. You can ask for a try-in, or you can go all the way to the final denture because you have all the information that you need from the existing denture and that you are reproducing in a new denture. Sometimes what I do is I start by scanning the existing denture of the patient, and I modify it like you see here. I add wax, I reline, or I do whatever I need to do to get the information that I need from the existing denture. You see here interocclusal relationship, and here is the digital design of the denture. And then what I recommend is that to do a try-in, because in this step, we are scanning with the intraoral scanner here. We are not using a laboratory scanner, and we might have some inaccuracies because intraoral scanners are made to scan intraorally, not extraorally. So you might be able to get a very nice duplicate of the situation that you've scanned, or you might not have the exact duplication, and you may need to do an additional reline. So my recommendation is to go for a printed try-in, correct what you need to correct, and then go for the final denture. And this is a very interesting workflow because it allows you to move much faster when fabricating a new denture. This is the last case that I want to show you. And this is a case of partial denture. So this is a case where we wanted to try to see if we can make an upper partial denture for this patient. So we took an upper and a lower impression. And because we have teeth, we were able to get the interocclusal relationship. And after that, we have asked the technician to mill us a try-in of the teeth. And then we have asked the technician to make a cast partial. And we wanted everything to be done without using a real model or a conventional flow. So we have asked the technician to mill everything: the teeth, the resin base, the teeth and the resin base, and to fabricate the cast partial with laser microfusion. And we wanted to do the try-in, so we made all the pieces interlocking so we could try in that removable partial denture. And here you see that we also wanted to play around and see if we could do it also with the same technique of little Legos, like interlocking pieces so that we could do a try-in without we could do the whole workflow without having to use the conventional technique of making partial dentures. And here you can see the comparison between the PEEK framework and the metal framework. If you could look at so we cannot do a roach, so an eye-bar on with the PEEK because it would become too fragile. So you can see here you have this type of anchorage, while on this with the metal we were able to do a roach. And this is the aesthetic result with the cast partial, and this is the aesthetic result with the white partial. Not much better, but we can see that it's still, you know, the patient wears the cast partial, he doesn't wear the white partial. Just so we can finish, we have the workflow options when we're doing when you're using the digital technology. You can use the existing dentures and reline the existing denture and take all the information from the existing denture. So you reline them, you take bite registration, you change buccal, you change whatever you want to change on the existing denture, and you scan all these information. And then the lab has all the information they need to do the digital design. And then they can send you a try-in denture, and then you have your final denture. If you go starting from scratch, you can start with an initial impression for the upper and lower. And then you get your milled wax rims. And at that level, you can correct your impression if you have missing information, like in here. And you can retake your CR registration. Then you have the digital design. You do your try-in and you get to your final denture. It's very important to understand that you don't have to stick to one workflow. You can start conventional and then move to digital. You can start digital, go back to conventional. It's up to you, up the clinical scenario that you're looking at. And what's important is to understand the capabilities and the potential of those different workflows and how they can help you solve your cases. We don't want to go digital just because we want to go digital. We want to go digital to make the quality of our prosthetics better, and we want to help us move a little faster. Just to conclude, the scanning of edentulous or partially edentulous arches is possible. It's of clinical acceptable quality for the maxilla. We don't have any data on the mandible, but as you can see, it is possible, and it's just a little, it needs a little bit more experience, and sometimes saliva can be a problem. Digital bite registrations still need to be developed because it's more like a physical step still. But I think it's time to get involved in the digital scanning, designing, and manufacturing. And we need to adopt the technology and adapt it to what we need so we can give the best to our patients. And I thank you for your patience. And I thank also all my colleagues that have given me cases and have worked with me on all those research projects. Okay, and I am looking forward to all the questions.
Thank you so much, Dr. Najla. It was very inspiring webinar lecture that you dived us to the very important aspects of digital scanning of the edentulous patients and partially edentulous patients to provide prosthetic rehabilitation for those patients. Just once again, if anyone has any questions, so please write it down. Otherwise, I have one comment that when you mentioned about the digital workflow, that you can have a good communication with your lab technician and be collaborated to see what the design. It's really very important because with the digital workflow using communication, nowadays communication like a Zoom or something, even the dental technicians are far away from your clinic, so you still can you have a session to discuss those designs and the treatment production for the denture. So that's very important, as you mentioned. So just I would like to mention about that.
Thank you for your comment.
Yeah, thank you. I think they got understood the lecture very well, so I guess that's why they don't have any questions. So
okay, very good. It was good to see you all, and thank you for coming to this. And great website, the Digitodontics.
thank you so much. So to conclude our webinar, as a tradition for Digitodontics, we would like to present a certificate of appreciation. We hereby express our sincere appreciation to Dr. Najla Chebib in recognition of her contribution as a live webinar speaker for the Digitodontics Webinar Series on the topic of digital scans and removable prosthodontics that was presented on Tuesday, July 4th, 2023. So once again, Najla, I thank you very much for your time and effort. You inspired us as usual with the latest technology to provide high quality treatment for edentulous and partially edentulous patients. Thank you so much, Najla.
Thank you.
Thank you. So just I would like to mention we have a few webinars in coming days. So after tomorrow, we have another specific webinar talking about the mandibular reconstruction for the maxillofacial defect patients. So stay tuned and join us for the next webinar. So thank you all.